Welcome to the LifeWorks Living Well podcast. I'm your host, Mark Hennick. This has been a show about what it takes to live well. And if our 3 seasons and more than 100 guests so far have taught me anything, it's been that living well isn't an accident. Well-being is a verb. It's something that we do. It's what we do with what we have, what we do with what was done to us. Well-being is what we do for our future selves and all those who come after us. Well-being requires physical, mental, social, and indeed financial elements, without being any one of those domains alone. One of my most pressing concerns as a lifetime mental health advocate is the trend of reductionism that we're seeing, of oversimplification of mental health awareness. Whether it's the toxic positivity of no bad days, the error of conflating violence with mental illness, the myth of the chemical imbalance. These are all, in their own way, counterproductive to moving our collective understanding of mental health forward. The issue that I'd like to tackle in this episode, I think, is a culmination of these types of simplifications. Next spring, Canada is set to move forward with what will be among the most expansive, permissive assisted dying laws in the world. Indeed, this is already well underway. Medical doctors in Canada will be permitted to actively end the lives of people with mental illnesses, solely for the reason of their mental illness. The individual is not required to be dying or terminally ill. A primary criterion, though, is that their suffering feels grievous and unbearable, which I can assure you from extensive personal experience is a suffering that depression routinely inflicts on people. But the most concerning for me as a mental health advocate is not what is or is not required of the individual who is suffering. People know more about their own suffering more intimately than anyone else possibly ever can, so their plight is a given. My grievance is what will not be required of the government and healthcare systems that failed people to begin with, that enabled their avoidable suffering to become so grievous to begin with. Mental illnesses are not all in your head. The brain is necessary, but not sufficient for people to suffer from mental illnesses. We all struggle, but to suffer means to struggle alone. That's our problem as a society. That's not the fault of the individual with the mental illness. People don't fail their treatments, but treatments sometimes fail people. Now, there are many other aspects of this very important topic that I want to explore in this episode, and although I often do talk to myself, that's not why you're listening to today, to listen to me. So I'd like to bring in some of the leading experts to help me unpack this a little bit further. Dr. Sonu Gaind is Chief of Psychiatry at Humber River Hospital in Toronto, as well as the co-director of the Adult Psychiatry Systems Division at the University of Toronto's Department of Psychiatry. Dr. Harvey Schipper is a professor of medicine and an adjunct professor of law, also at the University of Toronto. They join me today on Living Well. Gentlemen, thank you so much for joining me on Living Well today.
Glad to be here.
Thank you, Mark, and thank you for taking on this very challenging topic.
Well, this is something that I'm so passionately interested in and want to communicate with the public, because I feel like the discussion around medical assistance in dying, MAID, as we'll refer to it very often here, has been seen as an issue, or it's been sold as an issue of rights, of equality for people with mental illnesses. Now, I had Dr. Tom Insel on this show in the past. He was the former director of the National Institute of Mental Health. And he talks about the person, place, and purpose in the maintenance of mental health and recovery from mental illness. He really takes a biopsychosocial view of mental health. So I'm hoping that we can just start by talking about what from a scientific and clinical perspective, what mental health actually is, what mental illnesses actually are, so that way we can sort of level set this conversation. Sonu, why don't we start with you? What's the prevailing view of what mental health and mental illness actually are right now?
So in some ways, you can consider those, I wouldn't necessarily say different ends of a spectrum, but they fall on a spectrum. And mental health is something that we all strive for. And we can strive with many of the social supports that you actually, I think, alluded to in your beginning comments, because it's not only about how we think, it's how we live. And whether society affords us the ability to live with dignity and to live well with people we love, and to do things that are healthful for us. Mental illness is something that can impact mental health. It can be as grievous as any physical illness. And it is something where we know people suffer from various mental illnesses, from depression to schizophrenia to bipolar to many others, anxiety disorders, etc. But what we do not know, and this is a fundamental difference between mental illnesses and the vast majority of other medical illnesses that people talk about MAID for, we don't understand the underlying biology of the vast majority of mental illnesses. We don't fully know why they happen. It's an interaction between biology, psychology, and social. As Dr. Insel would say, the biopsychosocial elements all interact. And in that context, when we are then saying, well, now we are calling a mental illness, quote unquote, something that can never get better, something that's irremediable, which is what the public has been told MAID is for, that's actually a fallacy. And so right at the start of the conversation, it's not to say that mental illnesses always improve, but for us to provide someone MAID, we need to be able to predict that their mental illness will not improve. And that is impossible to do. And so right off the bat, it means that our society will be providing MAID for a reason that we actually, or for the wrong reasons, because we'll think we're doing it for one thing. It will really be for other things, which I'm sure we'll touch on. And to me, that's dangerous, to provide death for one reason, pretending it's for another.
Now, Harvey, there was a researcher out at Queen's University, Dr. Heather Stewart, an epidemiologist, and I heard her talk about how she focuses on stigma reduction and what causes stigma, how we overcome stigma. And I've heard her talk about how when we bang the drum of biological determinism too hard, that embeds stigma further, that your brain is broken. And that's the mechanism of action for mental illness. Have you found this in your work as well, this over medicalization of mental illness being a barrier to people actually recovering?
Well, I think it is, and it plays in a number of ways. One is in their relationship with others and in their relationship with the workplace, they get tagged with a disease which carries a stigma which may not be appropriate to what their particular circumstance is. We spent many decades moving society away from stigmatizing people with cardiac disease and saying, well, you're not going to be able to work in the office the same way, you won't get promoted. And we're nowhere near that with mental illness, in part because, as Sonu has pointed out, we really aren't very clear about what the definitions are. And to one stigmatize, and my God, to end the life of someone based on the presumption of a diagnosis which you can't even define is a pretty frightening kind of concept. And without being an alarmist, it's the same kind of thinking that stands, for example, behind eugenics and other things, saying, well, these are people whose lives are somehow degraded. We value the brain more than anything else, in this society. And they're degraded, and therefore they're of less worth to the society. So this is all okay. And you see these extreme cases, where someone is terribly despondent, say because of a broken relationship. And the symptom complex, and I'm not the psychiatrist that Sonu is, but the symptom complex of someone bereft in that kind of moment is awfully hard to distinguish between that of what, more conservatively would be called a serious depression. And yet someone could meet the box, if you will, and have their lives ended.
This raises an interesting, so when I was doing casework for the Canadian Mental Health Association, I routinely met young people especially, who had just a variety of different diagnoses. They were almost accumulating diagnoses. And it didn't even, I'm not a doctor, but it didn't even seem to make sense that there was overlapping stuff, that the boundaries between diagnoses were fuzzy. It wasn't entirely clear what they were going through. And then I started to realize, partly through my own experience as well, that their treatment, the people treating them probably didn't really know what they were actually experiencing either. It was a bit just shooting in the dark and seeing what sticks. And that's kind of the nature, it seems, of mental health treatment now. It's not like you go in for a course of chemotherapy, and then you get to the end of your treatment regimen and there's nothing left you can do, that we're still kind of groping around in the dark with treatments. Sonu, is that an accurate way to characterize how we treat or figure out how to treat mental illnesses still with that blunt force?
So what I would say is I think we're improving at getting better at treatments, but it is still a bit of a shot in the dark. Maybe not as fully blindfolded in the dark as it used to be, but we are improving. But what I would say is this, that again, when we're talking about the idea, because think about what we're talking about. We're talking about the idea of providing death as a treatment for suffering. And that's a very different thing. When do we then think that now it is something that we as a society will make it easier for you, who might be potentially suicidal, as part of your mental illness symptoms, and we will now provide you an easier access to death? And, just on this topic, I should just point out, I'm not a conscientious objector. I actually chair my hospital MAID team. What terribly troubles me and what I've seen over time is this expansion that Canada is having with MAID. That is something most people have no clue what it truly means, in my opinion. And it's this expansion to all sorts of marginalized and vulnerable populations, including those with mental illness and psychosocial suffering, many of whom would actually be able to recover from their mental illness given the proper circumstances. But now will be provided an enticed path, and I call it an enticed path, to an easy and seductive relief, quote unquote, of their suffering through MAID. That's highly problematic. And in my view, I actually think that our policies, I think, have been driven by the perfect storm of a number of things, including the lack of evidence guiding policy. In fact, at times evidence being ignored in policy, by a particular type of ideology, which I think you alluded to earlier in your comments. And also it's largely been fueled by the public misconception and myths that are out there about what expansion actually entails and what people would truly be getting MAID. And as we expand it, by the way, I would actually say the term medical assistance in dying is incorrect. If you have
I wanted to ask you about this, because that's where that boundary crosses over, right? When recovery is possible, and you ask yourself the question, well, why isn't this person recovering? Is it because there's no treatments left, or because they didn't have access to the treatments that they should have had for whatever reason? Then they're not dying anymore. They could recover from their illness. So the doctor is doing something very different. They're not assisting them to die. It's assisted suicide.
It absolutely is, because it's no longer helping someone who is dying to die. We're now providing death to a non-dying person who may well have decades left to live, and who we actually cannot, with any scientific integrity, and these aren't my words, CAMH actually reviewing this issue has said that it's not possible to predict irremediability, when a mental illness won't get better in any particular individual. So think about what we're then doing. We're taking somebody in their period of transient despair, because we can't predict that they will never get better from the mental illness. Their despair with mental illness is often compounded by life suffering, poverty, loneliness, isolation. And we know this from the statistics in the few European countries that provide psychiatric euthanasia. It is people who continue to suffer from poverty and loneliness who get it. And also twice as many women as men who get it. Terrifying gender gap for psychiatric euthanasia. And that's very different from MAID for a terminal condition, by the way. And so we're taking these people in their periods of transient despair, and we are becoming complicit with the symptoms of their illness by telling them, you will never get better, even though we can't really do that. And in their grievous suffering, they say, thank you for this relief of my suffering, I'll take MAID. And we will never know we were wrong with those people once they get euthanasia.
Harvey, I want to bring you in here, because this reminds me of the idea of choice architecture and consent and capacity, for that matter. When people have the most severe version of a mental health problem or illness, often that means schizophrenia or bipolar disorder, or something that could potentially be very severe. They often lose capacity, decision-making capacity, so they wouldn't be eligible for medical assistance in dying anyway. The people who are applying, it seems, are below that threshold, that they do have decision-making capacity, but you'd have to be, how could you not see how their decision-making is informed by their symptoms, by their suffering, by their social circumstance? So can people really make a clear-eyed view of whether or not they want to be alive or dead when they're suffering grievously like this?
Well, I don't think we really have a definitive answer to that. At one point, the Law Commission of Ontario commissioned a study to try and answer that question. You know, what capacity do people have in the context of intolerable suffering, which is the turn of phrase in the Carter decision. And the report that came out said, you know what? There's no way to measure that. There are no standard measures. There's no definition of it. We can't even define that. It's a very, very difficult and contentious issue. And it picks up on a couple of other themes. And one is, in a way, MAID is an infectious disease. You know, the people who spend their lives studying suicide, people ending their lives, tell stories about when a well-known public figure takes their own life, there's a little uptick in suicide. And when you particularly look at the younger generation, but also older people, there's a weird attraction of sort of walking at the edge of the cliff and do I step over or do I not? And I've seen that up close and personal with people who, from the moment of the Carter decision, which made this possible, become obsessed with the notion of ending their life. Because now I can do it. I can have the healthcare system provide it. And they're not even critically ill. They're not even depressed. I've coined a phrase which probably puts people off a bit called maidism, because suddenly you have an expansion of this idea in a very kind of strange way. To pick up on Sonu's other theme, having been around policy-making circles for a long time, it is utterly striking to me how this has been driven by willful ignorance of evidence in the face of ideology. If, for example, you want to license a new airplane or a new drug, or even change the packaging of a drug, there are a whole series of evidence-based steps you need to go through in order to do that. And the public is strongly supportive of it. And now you declare, as Quebec in effect did in the early days of this discussion, that MAID is a medical procedure. And now you're putting in a medical procedure, willfully ignoring the safeguards that you set out for every other medical procedure. What's the evidence? Go slowly, expand slowly. We don't do that. And I've sat in on Senate and House hearings and been working with senators. And you say to them, there is no evidence or there is contrary evidence. And what they'll often fall back on is a legal construct. Saying, wait a minute, this is defined law. The law says you can do it, therefore the discussion is closed. And in the discussions in the mental health group, in the federal expert panel on which Sonu and I participated once upon a time, in the mental health group, as I understand, I was in a different group, but we talked often. The people who were pursuing a rights-based argument were saying, this is a legal matter. It is settled law. When in fact, you come to the bedside and it's not settled law. What's the patient's state? What's their capacity to decide? This isn't just around mental illness. It's around terminal illness as a whole. I suppose my Andy Warhol moment was, I was asked on one of these legal panels, do I think about Carter at the bedside? And I said, no, I think about my Hippocratic oath. My oath is to take care of a patient, to relieve their suffering, to attend to their illness, to be holistic about it, and not to rest on a one epistemology, one way of thinking, which is legal, saying, okay, we've defined a legal window, follow it.
Yeah, you can't have it both ways. You can't say that it's a mental health argument, and when that doesn't work out because you're not following the evidence, switch to the legal argument
right.
instead.
And go right back to Carter. If you go right back to Carter and the definitions, the criteria, irremediable, suffering, the key words in the defining box for people, they're legal black letter, but translated to the bedside, every one of them, I think you would agree, is almost ambiguous.
Now, Sonu, I know you're, I just want to get in Sonu a little bit more here because I know you're tight on time, but I want to ask you on that evidence piece and the bedside piece. I mean, part of the nature of mental illness is suicidality. So how do you tell the difference between somebody who has a grievous mental illness, who's suffering grievously with their mental illness, and they're suicidal versus not, and making a request for MAID? How do you tell the difference between a cogent request for MAID and somebody who's suicidal?
Well, that's one of the false reassurances that has actually been given, that we can actually tell that the difference, and we can't. So that's the end punchline that I'll get to in a moment. But I'll just really briefly comment on two of the things that came up before, because I think it leads right into this. This issue of autonomy, actually, even before getting to autonomy, when we're talking about the facilitation of things. We know that when you make things easier and more appealing, more people do them. That's one of the things that Harvey was alluding to in terms of the suicide contagion effect, that when it's in the media and romanticized, more people actually do undertake suicide. And part of the problem with this is that suicide is very ambivalent. Most people who try suicide do not end up actually ending their lives by suicide. So it's not that they continue to want to end their lives for the balance of their life. It's a transitory period for the vast majority of people. And so is that true autonomy? When in that moment of suicidality, we may make it easier, we might even romanticize it. Look at the terminology used for expanded MAID about how it's all about your choice and your autonomy. And it's not, because I would challenge the autonomy issue this way. We talk about having a death with dignity. I question whether people can truly have an autonomous choice to want death with dignity when they have not had the opportunity to live with dignity, because society's failed to provide them the supports they need to live with a chronic medical or psychiatric condition or disability. So that's a fallacy. And that autonomy fallacy is a key one, because there are some people who will have more autonomy, but those are the people who've always had the chance to live well. It's a privileged autonomy. And so some people will actually get more privileged autonomy, but it comes at the expense of marginalized populations who are seeking this not because they actually want to die, but they want to live better and they don't have that chance. So to me, that's a false autonomy. And for autonomy, you need choice. So it's not a true choice. And in terms of the distinguishing suicidality and the evidence, this is what we found in the international evidence years ago, and it remains the same. That when you have a request for MAID for a terminal condition, there you can tell the difference. Those typically aren't requests of people who are traditionally suicidal. They're actually wanting to avoid end-of-life suffering and intractable pain. However, as you expand it, when it goes to psychiatric euthanasia or psychiatric-assisted suicide, then you can't tell the difference. Then people start to have overlapping characteristics who seek psychiatric euthanasia, and they have overlapping characteristics with the same people who benefit otherwise from suicide prevention to get them through a period of suicidality and live better. But instead, what we now would be doing is saying, yes, we become complicit with your suicidality, and we will provide you the death you're seeking in an easy way. Now, remarkably, when you talk about evidence, even the people who push for expansion, the expansion activists, their arguments have changed over time. They actually acknowledge, to me, this is remarkable. They acknowledge that people who could have gotten better will get psychiatric MAID. The Quebec Psychiatric Association literally says that somebody who gets MAID, regardless of their reason for psychiatric illness, could have gotten better and regained the will to live. But it's an ethical decision. And this is part of the problem. We're pretending that ideology is science. That's part of the problem. And, in the latest federal panel report that came out, this was supposed to provide some guidance, protocols, and safeguards for providing psychiatric euthanasia by next year. And remarkably, it didn't do any of those. Not only was it unable to provide any evidence, because there is no evidence that this can be done safely, they did not even provide any standards of saying the treatments that might be required. Literally said that that it's not possible to determine fixed rules for how many treatment attempts, how many kinds of treatments, and over what period of time treatment should be provided before providing death for mental illness. They fall back again on subjective assessors, which will be potentially ideologically based, case-by-case judgments. They are saying that this psychiatric euthanasia implementation can be fulfilled without adding new legislative safeguards. And really remarkably, they're even saying that psychiatric euthanasia, they are acknowledging psychiatric euthanasia and MAID may not even be different from suicide. They're saying that I actually am missing the quote here, but it's really quite striking because they're essentially acknowledging that these things may not be different, and yet society is making the ethical choice to provide it nonetheless.
Right.
That's
which is essentially, that's anti-suicide prevention. It's actively endorsing and administering suicide, which it seems antithetical to everything that the mental health movement has been pushing for the entire existence of the mental health movement.
Well, this is the false argument of discrimination, right? The overly simplistic idea that because somebody is able to access this for terminal cancer, if we don't also provide it for you when you have depression in your 30s and you might get better, but now you want it, that's discrimination. To me, it's discrimination to pretend to that person that we know they'll never get better and we'll offer them a easier death, and we're not telling them the truth. It's providing, and so in a nutshell, to me, it becomes, as we expand these MAID laws, the real question becomes, which mistakes do we want to make? Because we're always going to have some people arguing, well, this person maybe should have been able to get MAID, but safeguards prevented them. And on the other side, as we expand them, we'll have some people who we absolutely know shouldn't get MAID. We're also already seeing the headlines of this. I die when I run out of money. People literally saying that MAID for their disability is actually something they're seeking purely for financial reasons. These are cases reported in the media. Some of them have gotten MAID. Some of them are in the process of going through their applications. And to me, those are people who I don't think society would want to provide death for their life suffering, and yet we will be. So question is, how many wrongful deaths are too many? I think one.
Mm. And there needs to be legal accountability for the government to answer that question as well. Sonu, I know you have, I already kept you longer than you were able to stay, so thank you for indulging me. Harvey, are you able to stick around for a little bit longer? I'd like to continue the conversation with you.
Sure.
Great.
And Sonu, it's so good seeing you again.
Likewise, great seeing you, Harvey and Mark. Keep up the great work in getting the message out and educating people. It's really important. Thank you.
Likewise. Dr. Sonu Gaind is Chief of Psychiatry at the Humber River Hospital in Toronto. Dr. Harvey Schipper, who's going to stick around and talk a little bit more with me, is a professor of medicine at the University of Toronto. This is the LifeWorks Living Well podcast. I'm Mark Hennick. We'll be right back.
In our changing world, there is an unchanging principle for success that inspires us. By improving a person's life, we'll improve how they perform at work. We are LifeWorks. We are the world's leading total well-being provider. We are innovators with tech-enabled solutions. Our mission is to improve people's lives by supporting the whole person, their mental, financial, physical, and social well-being. These people are the heart of successful organizations, leading these organizations to a more resilient future and making a real difference in the world and in our communities. Improving lives, improving business. We are LifeWorks.
Well, that's it for us this week on Living Well. Many thanks to all of my guests today, and thanks to you, as always, for listening. Make sure that you like and subscribe to the show wherever you're getting it: YouTube, Apple Podcasts, Google Podcasts, Amazon Music, Audible, Spotify, iHeartRadio, and everywhere else. You can go back and check out all of the episodes from our 3 seasons so far on any of those platforms, as well as at livingwellpod.com. You can connect with me directly on Twitter, Facebook, Instagram, LinkedIn, and YouTube at Mark Hennick. And I stream all the videos from all of the episodes up there, so let me know what you thought about the show in the comments section. If you found it helpful and inspiring, please share the episode with your friends and with your social networks. Thank you so much again for sharing some of your day with me today. I've been your host, Mark Hennick. Until next time, take care and live well.